This was a 61-year-old female, type 2 diabetes and hypertension, which both had been worsening recently, previously diagnosed with primary hypothyroidism. And she had gained 20 to 30 pounds in the recent 2 years, had noticed bruising, bleeding, lower back pain, and also noted prominence of the bump in her back, and she had fullness in her face and increased hair growth. Her past medical history was not unusual for a 61-year-old. I don't think there's anything here that is particularly of relevance. And she was on insulin for her diabetes. She was on medications for her hypertension and her thyroid replacement therapy. And so she had presented to her primary care doctor, and as often is the case, sometimes the initial workup is somewhat random, and she had a random morning cortisol of 29, which is certainly elevated, but not a very good predictor in terms of diagnosing Cushing's. But her urinary free cortisols, as you can see, there was one here in January 09, which was very much elevated, an upper reference of 45, and this was 227. So clearly meets the 3 to 4-fold elevation that we typically like to see, although she also demonstrates another teaching point that she also had a fairly unremarkable urinary free cortisol not 2 months later. So again, as the recommendations from the Endocrine Society suggest, you need to do several of these to rule in or rule out Cushing's. She had also had a number of dexamethasone suppression tests, and this is really a very wonderful and extensive workup that we would see from an outside endocrinologist. We typically don't see anything like this. Oftentimes we have a bunch of data points and no idea whether they were taken before dexamethasone or after dexamethasone. It can be a bit of a needle in a haystack, but she actually had a full chart, and what this demonstrates is that her baseline serum cortisol was 12, and after the standard little dexamethasone suppression test, which is 0.5 milligrams every 6 hours for 48 hours, her cortisol only suppressed to 7. And again, the suppression should be to 1.8 or less than 1.8 microgram per deciliter. And then this was followed by the so-called high-dose dexamethasone suppression test, whereby the patient takes 2 milligrams of dexamethasone every 6 hours for 48 hours. And here we look more at the degree of suppression from the initial value, and the sort of stringent criteria which suggest pituitary origin Cushing's are a 90% suppression in serum cortisol, and you can see that she met that criteria. She suppressed from 7 to 1 microgram per deciliter. So this data really suggested that she had Cushing's and that it was likely pituitary origin. Her thyroid function was normal, and she had an initial brain MRI outside which was read as normal, which, as we heard earlier from Dr. Oldfield, is not an uncommon scenario. This is her physical exam. You can see here this picture of her arms, and you can see some of the sort of libido that she has, the recent sort of wounds and bruising, ecchymosis, etc. She was hypertensive, and she had a number of these ecchymosis on her arms and legs. This is a picture of her back, and I think you'll agree there's some prominence there, and that typical Cushingoid appearance that we see, sort of like almost urticarial type appearance that these patients seem to have sometimes. But she did not have striae on the abdomen, and really, again, just to make the point that these physical signs are not present in everyone, but clearly we have to look carefully for them. Her neurological exam was fine. She had some proximal weakness, but nothing very dramatic, and this is just a demonstration of her doing her sort of squat test, and you can see here in the picture that she is quite centrally obese. So we did a couple of other urinary free cortisols, and these again were very elevated, as you can see, both higher than 3-fold elevations. And in light of her negative outside MRI, and I think we're going to see internal MRI in a moment, but we elected to do inferior petrosal sinus sampling, and in red here on top you see her right inferior petrosal sinus. This is on the baseline. The x-axis here is time. The green is the left inferior petrosal sinus, and the blue is the peripheral blood of the inferior vena cava. And what this demonstrates very clearly is that at baseline she had a central to peripheral ACDH gradient looking at the right inferior petrosal sinus to the peripheral blood, which was 25, so clearly higher than 2, which is the typical cutoff. And following CRH, these presumed tumorous corticotropes released a burst of ACTH, leading to this even higher gradient after CRH, about 2 minutes afterwards, of 87. So this study would suggest that this patient has central Cushing's, and as Dr. Oldfield has said, it's not a really good predictor by any means, but if we were going to say which side the lesion was likely to be on, we would say the right side, but probably only a 60-40 predictor.